This lecture is regarding central nervous system tumors. This is one area where it is important to understand and be able to recall the etiology and epidemiology. So the incidence of central nervous system tumors is actually something that's on the rise. Within the next 12 months, you're expected to see greater than 200,000 Americans developing brain tumors. Now, 80% of central nervous system tumors are primary, 20% are metastatic. 60% of central nervous system tumors are in adults are actually supratentorial. That'll make more sense as we go through this. Greater than 120 different types of brain tumors exist, which really is what makes it so difficult to treat these tumors, from a medical standpoint, that is. So survival rates do vary significantly. The 5-year relative survival rate following diagnosis of primary malignant brain tumor, which does not include lymphomas, is 32.7 for males and 31.6 for females. So the 5-year survival rate is approximately 30% for both males and females, which is significantly lower than we would like to see. Now, the 5-year relative survival rates following diagnosis of primary malignant brain tumor by age, it is better the younger you are. So at 0 to 19 years old, we have a 63% survival rate, 20 to 44, a 50.4%, 45 to 64, a 14%, and then older than 65, only about a 5% survival rate. So the risk factors here, the age spectrum really spans both extremes of life. So pediatrics, less than 15 years old, or geriatrics, greater than 70, are at a higher risk. This is one area, as opposed to many neurological conditions, where Caucasians are actually considered at a higher risk. Okay. Family history is significant. Occupational and environmental exposure. There's been numerous environmental exposures that have been considered high risk. Formaldehyde being one, vinyl chloride, acrylonitrile, rubber, and ionizing radiation. So with regard to pathophysiology and the relevant anatomy, again, this is another area where referring back to your focal anatomy is the key. Depending on what exact region of the central nervous system is impaired, you will have your exact symptoms and expectations. When classifying brain tumors, there are numerous different types of brain tumors. Unfortunately, this is one area where it's important that we really just read through all of this iBook, understand everything, and memorize it. I do have some accompanying information that I can share with you. In years past, some students have made mind maps that have given me permission to share, so I'll share that with the class. But in general, this is one of those areas that from a board standpoint, as well as a practicing standpoint, we just have to know as much as we can, try to remember them so that we can recognize them. Now, the end game here, we're going to have to understand what the different types are and how much of the brain each of them will affect, or the spinal cord for that matter. But at the end of the day, our treatments are going to be related to the focal lesions themselves. So we're really going to be treating the region of the brain that's affected and the symptoms as a result of that region of the brain that's affected. So with specific types of diagnosis, it's important that we know them, but it's not necessarily going to impact your direct treatment decisions, with the exception of some of the tumors where you know that a person has more of a significant life-threatening illness than others. So primary brain tumors, the good news about primary brain tumors is that they are very obvious on CT scan. And the reason I say this is good news is because many brain tumors are not visually easy to see. And the concern there is that people will often go for many years without being treated because they're unable to define or find the tumor. So with primaries, the good part of them is that you can see them. Now, they do originate in the brain themselves, the spinal cord or the supporting tissues. CNS Neoplams in children are largely primary in nature. Sorry about that typo. So in children, they're primary in nature, which probably is also the reason why we have better outcomes in children, because they're able to be found out sooner. So the good news here also, they do not typically metastasize due to the lack of lymphatic system in the brain. So while hearing that a primary brain tumor is the diagnosis definitely is scary, it is actually, in fact, a little bit of a better prognosis than many of the other type of tumors. Secondary, metastatic brain tumor, is naturally a significantly different story. So these do originate outside of the brain, and as a result, they work their way into the central nervous system. Incidence, 30% of all brain tumors are considered secondary or metastatic brain tumors. Prognosis is very variable. However, the mean survival is approximately 3 to 6 months. CNS neoplasms in adults are largely secondary in nature. Again, sorry for that typo there. It's secondary, not 20. The original tumor site is often the lungs, breasts, GI, or GU tracts. Cancer cells can spread within the CNS via cerebrospinal fluid or intracerebral circulation. So again, we're coming back to our understanding our anatomy and understanding our focal brain lesions. With regard to tumor nomenclature, essentially you can refer to these 5 different base terms. We have adenoma, blastoma, glioma, carcinoma, and sarcoma. So these 5 base terms are really the baseline for your description of the tumors. After that, there's additional terminology that helps identify the location, the severity, or the type of tumor. For example, an adenoma. This is a benign tumor arising from a gland. A primary example of that would be the pituitary adenoma. You also have blastomas. These are malignant tumors with undeveloped cellular characteristics. Medulloblastoma and glioblastoma multiforme are common examples. You also have gliomas. These are benign or malignant tumors that arise from supportive tissue of the brain. Some examples are astrocytomas and oligodendrogliomas. You also have carcinomas. These are malignant tumors arising from the skin or lining of the GU, GI, respiratory systems, such as lung cancer. You also have sarcomas. These are malignant tumors arising from connective tissue, blood vessels, or lymph system. So we have the baseline terminology, but let's move on to the effects of central nervous system tumors. So the effects, one of the most profound effects is not only the actual lesion itself, but it's the displacement that that lesion causes. So the mechanical displacement of the brain and the spinal cord. If a tumor were to grow large enough, even if it's benign, it can actually push into the skull and put pressure on the opposite side of the brain. So you can actually have the same type of injury as you would find with a concussion, like a coup, counter-coup injury, where you may have a tumor in the frontal lobe, but you also demonstrate occipital lobe impairments. Another major factor here is, depending on location, you could have blockage of the cerebrospinal fluid circulation. This would ultimately cause similar symptoms to a hydrocephalus, which again is causing increased pressure, which is going to cause a secondary brain lesion. The cause is the neurological effects. You have them by the compression of the cerebral tissue, including the cranial nerves, invasion or infiltration of cerebral tissue, and that's the actual focal deficit from the tumor itself. And then in many cases, you'll actually see a tumor that is large enough with significant enough pressure can actually cause erosion of the bone. So the other effects here, you can also have secondary changes with cerebral edema and elevated intracranial pressure. So at the end of the day, the pressure is really a leading factor in symptoms in many people with brain tumors. Vasogenic cerebral edema. So this is essentially a challenge where you have that increased cerebrospinal fluid causing increased pressure within the brain, which ultimately causes edema. So this leads to seepage of the plasma into the extracellular space between the layers of the myelin sheath. Ultimately, what happens here is you not only get increased pressure, but you also get an imbalance in your cellular activity, which leads to electrochemical instability. So now it's not only a matter of pressure, but it's a matter of a instability on an electron, neutron, proton level. So this can cause multiple different issues. This can cause a breakdown in tissue. It can cause an opening of the blood-brain barrier. In some cases, the brain could tolerate it, but ultimately over time, we're unable to tolerate it. So ultimately, what we see is a decrease in the amount of brain tissue, a decrease in cerebrospinal fluid volume, and a decrease in cerebral blood flow. So essentially, what starts off as being too much pressure, ultimately remains with too much pressure, but it actually ends up breaking down the tissues and the cerebrospinal fluid within the skull. So a few signs and symptoms may be noted initially, but usually it's not until the brain can no longer compensate that you really see and overcome the intracranial pressure increasing enough to overcome the system and cause symptoms. Signs of elevated intracranial pressure. This has been discussed in other topics, but headache is by far the most common. 50% of people, even with a very slight increase in intracranial pressure, will have a headache. Retroorbital or generalized headaches, so they'll feel it right behind the eyes or in general. The symptoms can be intensified by activities that raise your intracranial pressure. Straining, stooping, exercising can all cause increased pressure, which causes more of a headache. Overall, the cerebrospinal fluid drainage is better in the erect position, so many people with a brain tumor will find that they have headaches in the morning that starts to resolve throughout the day. So you can also have the headache being caused by irritation, traction, or compression of pain-sensitive structures, including the blood vessels, the venous sinuses, cranial nerves, and the dura mater. In conjunction with this, with the headaches, you'll frequently see nausea, vomiting, papilledema, seizures in 10% of the case. Seizures are actually one of the common initial signs, and they're actually one of the reasons many people get diagnosed in the beginning. Tumor characteristics. This is where we really start to define a tumor. There's what we call differentiation. So this is the histological grade of the tumor. The tumor tends to mimic your normal tissue and your cellular architecture, but naturally starts to grow in an undefined manner and has abnormal growth, which ultimately leads to significant pressures. Now, the undefined manner is generally used to define a malignant tumor. Benign tumors tend to have very clear-cut, defined start points and end points, which does make them easier to resect in cases of surgery. So when you look at the difference between a benign and a malignant, benign, slow growth rate, non-invasive, well-differentiated, and low risk of reoccurrence. So if we can have that removed, we can have a very optimal outcome. Malignant tumors, on the other hand, have a fast growth rate. They do have invasion into the neighboring areas, very poorly differentiated, and has a higher risk of reoccurrence. Now the other category here is gliomas versus non-gliomas. This is a major differentiation between the type of tumors that you're going to see. Gliomas can be divided up into astrocytomas, oligodendrogliomas, and ependymomas. Non-gliomas are medulloblastomas, meningioma, pituitary adenoma, a schwannoma, and a primary CNS lymphoma. So it's important that you differentiate between the two. As we kind of go through the next few slides here, essentially we're breaking out and describing the different types of tumors, the gliomas, benign versus malignant, as well as the low-grade astrocytomas into the high-grade astrocytomas, breaking down even further. Okay, so what I really suggest you do in studying, because you don't need me to read all these details to you, what I strongly suggest you do is go through these slides here. I'm kind of going through them pretty quickly. You want to go through these slides and pull them out and separate them out into categories. Start by glioma versus non-glioma, and then break that down further and come up with your descriptors. In doing so, those descriptors are going to help you have a better baseline, a better understanding. Next up, we're talking about the diagnostic criteria here. So with the medical diagnosis, we can really break this down into the specific diagnostics of, type of tests, MRI, CT scan, PET scan, so on and so forth, but then also the descriptors or the classification systems. So the World Health Organization classifies brain tumors in a system of 1 to 4, 1 being did not spread beyond the structure of origin, 2 spread into adjacent tissue, 3 spread beyond its own region, and 4 involves another organ or distant site. So we'll take note of that. The World Health Organization has a 4-stage system, 1, 2, 3, and 4, with 4 being the most severe because it has spread the most distance. Next up, we have the Gleason system. This is actually a scale system from 2 to 10. Lower number means less aggressive tumor. So 4 and below is a less aggressive tumor, 5 to 7 is considered intermediate, and 8 to 10 is considered fast growing. So now we have essentially the World Health Organization, 1 to 4, higher the number, the more severe, and the Gleason system, 2 to 10, higher the number, the more severe. Then we have our TNM system. So it's TNM for tumor size, N for nodes, M for metastases. And the descriptors are going to be laid out in the next few pages. So tumor size is a 0 to 4 scale, and 0 being no evidence of a primary tumor, 1 being tumor only verifiable via biopsy, a T2 is confined to site of origin, T3 it spread slightly outside the site of origin, and T4 it has spread to other body parts. So we can relate this T section of the TNM system to the World Health Organization's 1 through 4. It's very similar. Now we expand further into our N, which is nodes involved. So a 0 has not spread to the lymph nodes at all. A 1, it spread to the closest or only a small number of regional lymph nodes. T2, it has spread to extent between nodules 1 and up to 3. And N3, it has spread to the most distant or numerous regional lymph nodes. Then we have our M, our metastases. A 0, tumor is not metastasized, and a 1, tumor is spread to other parts of the body beyond the regional lymph nodes. So naturally, the higher the number here, the worse the outcome is. So the staging here, World Health Organization, we have, again, the grade of 1 or 2. It's considered a slow growth. Now, the classification for this is more commonly a low-grade astrocytoma than anything else. Grade 3 is faster growth, which is anaplastic astrocytoma, and a grade 4 is a very fast growth, which is a glioblastoma multiforme. So essentially, based on the World Health Organization scale, we can look at growth rate, classification, and understand the severity of the person's situation. With respect to medical management, there are definitely many options. There's many experimental options as well. As of right now, because what we've discussed, how there's so many different tumors and so many different presentations of each type of tumor, there's no clear-cut standard in treatment. But that said, medical and surgical management is often preferred. There's traditional surgery, surgery with chemotherapy, with radiation, and then there's stereotactic radiosurgery. So within that surgical management, it's the most important form of initial therapy. If they can get in there and take everything out, the more they can get out without damaging neighboring tissue, the better. The more likely they're going to reduce the tumor load. As a result, they're going to take away the mass effect, they're going to take away the increase in intracranial pressure, and overall increase the effectiveness of the adjunct therapies. However, if the preoperative deficit is due to the destruction of brain tissue by the tumor, surgical resection will not improve that situation. If the deficits are due to compression, on the other hand, the surgical resection will have significant improvements in general. Complications of surgery are the same as any other brain surgery, so hemorrhage or infection or seizures, hydrocephalus, which is secondary to impairment of your reabsorption of cerebrospinal fluid. In some cases, you actually get a pituitary adenoma from having surgery. Aggravation of pre-existing cerebral edema as well. So often they're given significant medications, corticosteroids, anticonvulsants, pre- and postoperatively to try to prevent and control those type of symptoms. Now, in order to perform these surgeries, a person has to have a craniotomy. So they have to remove a portion of the skull, which overlays the tumor. Then they remove the tumor, and then they replace the bone on top. So as you can imagine, there's significant damage not only to the bone itself, but also to the matter, the dura mater, and so on and so forth, essentially leaving us with an opening in our blood-brain barrier and a high risk for infection. That other type of surgery mentioned, the stereotactic biopsy surgery, this is actually where there's a small needle inserted through the skull, and it's guided through MRI or CT scan, and actually the cells are suctioned out through that needle. In an ideal setting, this is an excellent option because you don't have to cut a large hole through the blood-brain barrier. You don't have to really displace a significant portion of the skull, and ultimately the healing could be better and easier. So in addition to these types of surgeries, you're also, after a brain tumor or a brain tumor surgery, you're going to have that high potential for increased intracranial pressure. In order to do that, you'll often see a bypass the blockage of CSF with a VP shunt. And when we take a little bit of a closer look, we can see these shunts will essentially come in, they put a ventricular catheter right into the third ventricle usually, but it doesn't have to be the third, but usually third. Then they'll have a shunt system that stays under the skull, and then they have a tube that comes all the way down through the neck and into the peritoneal cavity. And this actually drains cerebrospinal fluid out of the brain area and into the peritoneal cavity and gets reabsorbed by the body. Okay. So as we move on here, we have our radiation and chemotherapy. Naturally, you can read through these methods, but in essence, radiation is done in extreme scenarios when the tumor is inoperable or when they can't get the entire tumor out. Chemotherapy can be taken oral or intravenous. The blood-brain barrier, however, makes oral and IV chemo less effective. So that's something to consider. For chronic management, we're going to have essentially a very high, very strong steroid base. So Decadron is a common form here, and also to prevent the seizures, a person will be on an anticonvulsant, most commonly Dilantin. We'll discuss medications more significantly in other sections, so these aren't significantly important. Primary signs and symptoms. Again, this is all about focal lesions. It depends on where the brain tumor is, what the effects are going to be. But in conjunction with that, there are the generalized signs and symptoms. If a person has pressure that's increasing intracranial pressure or causing displacement of the brain, you're bound to have erosion of the bone, headaches, seizures, decreased cerebrospinal blood flow, nausea, vomiting, papilledema, mental clouding, and lethargy. So the progression of the symptoms depends on the type of tumor we're discussing, and essentially we're going to be looking at our focal deficits and using them as prognostic indicators as we're working with our patients. With regard to therapeutic management, this gets in depth here, but this is not for this course. So you can stop at Chapter 6, and that's all that's most important for you to know regarding CNS neoplasms.